Thank you very much for this kind introduction and for the invitation to speak at this symposium. I'd like to first reduce the noise outside. That's always the problem when we've got online. Okay, can you hear me better like this?
Yes,
yes, we can hear you now.
Okay, and can you see the slides?
Yes.
Perfect. So then I'll get start in order to share with you some of the experience. And it was, of course, great to have the talk of Professor Holt before on the specificities based on ADA and EASD consensus statement on type 1 diabetes. And I would like to introduce to you some special forms of diabetes you might encounter. But of course, in the past, diabetes was considered one disease. That's one of the very early manuscripts. Although India already very early on differentiated between a type 1 and a type 2 diabetes, looking at those who were having too much food and needed to back off that part, and those who would disappear within a high polyuria and polyuric syndrome. But as time moves on, we now know that diabetes is a group of metabolic diseases characterized by hyperglycemia, which can be based on defects in insulin secretion, action, or both. And of course, I will focus a little bit more on the younger population. And we all know that certainly in that younger population, the chronic hyperglycemia is associated with the long-term damage which needs to be prevented. And as mentioned by the previous speaker, education, not only mentioned by Tony Blair, but as well, I think, by all diabetes care providers. So the classical symptoms, I don't think for this public I have to repeat them. Although, of course, in pediatrics, just be aware, do we really can follow the HbA1c of above 6.5? Some questions still to be addressed. Of course, most often we will be faced in pediatrics with just a clear-cut syndrome, polyuria, polydipsia, weight loss. Although, of course, we would like to see them as early as possible, and maybe even earlier than the weight loss starts. So just a short classification of diabetes in order to make the rest of my talk, partially at least, a little bit more understandable. Of course, the type 1 diabetes, we had a discussion about that just before. The type 2 diabetes, which I think is still limited, certainly when you look in Europe around you, although we must be aware that it is going to increase and is increasing. And today, other forms of diabetes, which I really would like to draw your attention to. Here, ISPAT's clinical practice consensus guidelines can be of help, and do realize these are the ones of 2018. New update is coming freely accessible online from October onwards. And there again, we'll have an update on the classification of diabetes. Now, don't worry, I'm not going to go into all the details of the different monogenic forms, but it's definitely something people need to be aware of. And not only, I think, in the pediatric population, but just as much in the young adult and maybe even older adult population. Maybe there are more hidden monogenic forms which might request a very specific treatment than one is aware of. Again, quite a lot of mutations are known for neonatal diabetes. Some will lead to a passing by form, it's temporary, and others will be associated with a definite diabetes, but sometimes needing insulin, sometimes better treated with oral medication. We need to be aware as well in the genetic field that there can be insulin receptor anomalies or insulin gene itself anomalies. There are syndromes like the congenital generalized lipodystrophia or the short stature associated, the PIK3R1. Again, in pediatrics, cystic fibrosis can be associated, one of the exocrine conditions. And in the past, it was a very limited population which was diagnosed. But now we realize that this population is seen more and more often as well by our adult colleagues because we are aware of it. and we can go for the genetic characterization. Some other forms based on exocrine pancreatic conditions or endocrinopathies, maybe a little bit more rare in pediatrics. We've got the syndrome associated potential genetic conditions like the Turner, which is associated with higher increase, although a lot of children with the Turner syndrome would not have the diabetes, but it can be, and you have to be aware of it. Drug-induced treatment. I think this has been very relevant also to teach us sometimes about pathways leading to hyperglycemia, either temporary or more definite. Quite known, of course, are the glucocorticoids, asparaginase, different forms. Those forms who do not cause any abnormality in the insulin secretion have been associated with less efficacy with respect to their cancer impact. And then growth hormone and beta adrenergic agonists. Infections, congenital rubella, enterovirus, Coxsackie, cytomegalovirus, those are well-known ones. I think the verdict is still out whether type 1, at least, of the coronavirus SARS-CoV-2 would be a cause as well of diabetes. There are different research projects ongoing, which will help us to clarify, I hope, in the future, what the real impact has been on the incidence and on pathogenesis of type 1 diabetes. And then we've got the very uncommon forms of immune-mediated diabetes with the presence either or not of insulin antibodies, the polyendocrine autoimmune deficiencies, and as well treatment-induced influence of the PD-1 and the PD-1L1 axis. Also, learning something about the pathogenesis of diabetes.
उसके बाद सीधा वहाँ टॉरेंट वाले
Excuse me. Can you see the slides?
Yes, sir.
Okay, because there was someone commenting and I can only see slides but don't know what's happening for the rest. So, with respect to the classification of type 1, I just would like to have a little update on the questions we need to ask, whether we are still appropriate by saying there is one type 1 diabetes. I think maybe these recent papers and further research has demonstrated that we should really consider type 1 diabetes not as one single condition. There are maybe different endotypes, and these different endotypes might request different, at least, interventions to prevent progression to insulin deficiency. Should we include, as proposed in the paper by Insel et al., the preclinical stages of diabetes as diabetes? Can we do that? And can we as well try to have interventions for those earlier stages as well? Should we classify and how type 1.5 diabetes? Or is that a different condition? Is this an overlap? Should treatment be as well starting with one and ending with the other one? I think there is a lot of questions which are still open. Just for your, as a reminder, the paper on diabetes care showing the early phases and stages of diabetes and proposing really to consider this already type 1 diabetes. And as well, a little update on how the presence of these autoimmune markers may impact on the progression towards the end stage, hyperglycemia and the request for insulin as treatment. Anyway, many questions, and I'm listing them here without going into them in detail because I should tell you something about the rare cases of diabetes. And of course, all rare cases can't be addressed. So I'm just selecting 3 different ones where I hope that they might be for you interesting in order to consider always with care what diagnosis and what treatment needs to be provided when you're seeing a non-specific case with type 1 diabetes. I think just here as well, 2 further points on type 1 and the different endotypes. I think it is something we really need to consider, even if we try to get, on one hand, clarity in how we should approach treatment and diagnosis. Certainly in the adults, even in the pediatric age group, we need to consider and look out of the box in order to be able to really prevent progression and design a cure. Monogenic diabetes. Just one little update further is really, it is a different kind of treatment. So certainly in pediatrics, essential, or it's often, often a different kind of treatment. So be aware if you've got someone with a diagnosis below the age of 6 months, it is monogenic diabetes until proven differently. If you've got a very strong family history, it's becoming a little bit questionable whether it is monogenic, as we know that there are different families with 3 degree of type 1 classical autoimmune disease. Stronger point, of course, is in any age group after, say, 6 months, 1 year, who have no, for the moment, known autoimmune markers at diagnosis. High beta cell preservation is as well a sign that you should question what the appropriate diagnosis is. Is it type 1 or is it a monogenic form? And even with the current antibodies, we still have got a population without, even if you test all 5 well-known antibodies. In type 2, certainly in the Caucasian population, that might be different in India because, of course, the risk of developing with limited obesity, type 2 diabetes in the adolescent is more frequent than you would have in the Caucasian population. Same, of course, goes for the African population. If you've got no sign at all of acanthosis nigricans or other markers of the metabolic syndrome. And finally, if you've got a strong family history of diabetes without obesity. And I can tell you that I've had a family of 10, 15 people where 2 adolescents were diagnosed with a MODY. MODY, very simple one, MODY 2, where no treatment is requested. And in 5 adult family members, there was a diagnosis of type 2 diabetes. None of them were obese, maybe an tiny overweight, but nothing more. Caucasian family. And they were all having diet or even an oral treatment. They were all confirmed with a MODY 2. Now, how common is monogenic diabetes? And another question, how good are the data we have? How reliable? How many really representative data we have? Poland had a cohort, white Europeans, and they found between 3 and 4% to 12. Norway, as well, in a younger age group, they were only looking at 0 to 14, and they identified only 1.1%. The USA, multi-ethnic, they were looking at the 2 cohorts below 20 and below 6 months, found 1.4%, so quite different. But then if you look at the national study, really representative for the full Lithuanian population, which is mainly a Caucasian population, as far as I know. They had 100% of the pediatric diabetes population, and they found 7.6% of the entire cohort to have a potential prevalence of monogenic diabetes. So still there as well, there is a lot to be studied and to investigate. We're not yet there. Now, I would like to start this first presentation of a girl, 11 years old, who had a routine medical control, a glucosuria, and then when going a little bit further, she mentioned that there was as well polyuria, polydipsia, headache, weight loss, about 1 kilo. And when we tested further, she had quite a high HbA1c, 11.9, 107 millimolar per mole, normal pH, and hyperglycemia. So first thought, 11-year-old, weight loss, classical symptomatology will be a classical type 1 diabetes. However, you see, no obesity, so type 2 not probable. C-peptide really quite high, and no single insulin antibody. So question, is this a type 1? Probably not. Then going back into her family story, we saw that there were 3 male ones in the family of the father who had a form of diabetes, high HbA1c, insulin treated in the majority, and one with complications, a retinopathy. For us, it was a sign that we had to do genetic analysis, and we identified an insulin gene mutation, which was considered by the Exeter team as being very likely pathogenic. This kind of insulin gene mutation is happening most often in the neonatal phase, although this girl was much older, 11. It's autosomal dominant. We didn't have anything in the father, but we had a positive family history. Another important information is that this specific mutation leads to a misfolded proinsulin, and thus to the retention of proinsulin in the endoplasmatic reticulum, which really makes you consider, how are you going to treat this person? Is the treatment going to be best by insulin or by metformin or another oral drug or not? What is the risk? We considered insufficient data were there to start stimulating the beta cell, because if you increase the presence of that misfolded proinsulin within the cell, that might lead to an increase in the apoptosis of the cell. So we treated with insulin, but you can see this was way far from effective. First of all, there was a massive increase in weight. HbA1c, as you can see, was not at all up to what our objectives and mean values are. And we were talking about a really high insulin dose. Of course, we were frustrated, and the girl definitely as well. So we did some other tries, and so far not yet with the effect we would like to have. The only thing which was surprising is that when she would be very actively physically, that would have a real impact. But an adolescent girl now, 13, 14 years, physical activity is not high on her priority list. Based on her information, we asked the rest of the family to do some further testing. The father had never done any further testing. After, I think, 1 or 2 years and a bit of discussion with one of my colleagues, he did do some testing, and indeed he had as well diabetes with a high HbA1c, and now is treated with the GLP-1 analog and insulin. Grandparents on both sides also seem to be positive based on testing which was done after the girl in our clinic was diagnosed. So here we are stuck, rare form of diabetes. The competition between misfolded insulin and the insulin treatment might give insulin resistance. The injected insulin might have a different effect on the insulin receptor of the adipocyte. We don't know. GLP-1 analog, would we increase the risk for apoptosis based on an increase of intracellular misfolded proinsulin? For the moment, we're working closely together with the Free University, Miriam Knopp, in order to see how we can improve and identify the best possible treatment for the family. The second bit I would like to discuss with you, and just make sure that you're aware of this. I got a phone call from the family where I'm following one of the other kids, not with diabetes, with growth hormone deficiency. And the mum is in kind of a panic because her girl has a diabetes, HbA1c of 7.7, observed and detected by the family doctor, and without any evident symptom. When asking a little bit further, she might drink a little bit more, summertime, but nothing else. History of this girl was postnatally surgery for some congenital malformations, and further she was doing fine. You see, a little bit chubby, 160 with 66 kilos, no consanguinity. Only other thing was that the mother was diagnosed with type 2 diabetes, the brother of the mother was diagnosed with type 2 diabetes, and the grandmother was just diagnosed with type 2 diabetes. No obesity. 2 of them were treated theoretically with an oral drug. Although, next step was that the mother told me she wasn't always taking her treatment. Now, if this would be interactive, I would love to ask you this question. What kind of diabetes is this? I guess a lot of people would say D, but we can't ask. I can tell you, I invited the family quickly to come because it was a huge stress. Clinical examination, everything was fine in the girl, doing brilliantly. And we did a lab control in our lab. HbA1c was 5.4. Random glucose was 89. She had no autoimmune markers. She had a completely normal oral glucose tolerance test. So no diabetes, not for her, nor for her mother, or the grandmother, or the brother of the mother. What they had was an abnormal HbA1c and the mutant of the alpha chain, which is not at all typical for a Caucasian family, was present, and that had, with a specific method of Tosoi, which was used in one of the labs, resulted in high HbA1c. So here, the warning of this rare form of not diabetes, take care, because this is not diabetes, this is an abnormality in hemoglobin. And as we know, other hemoglobinopathies can lead to these kind of abnormalities and can lead to a wrong diagnosis. Luckily, the grandmother of over 80 just hadn't taken her medication yet, because I quickly, of course, we informed the family doctors. The mother had stopped her medication because she said, I feel always so dizzy if I take this oral medication. So you see, doctor, I stopped it. So very important, if you take HbA1c as only measure, which in pediatrics should never be the case, be aware that different hemoglobinopathies can lead to the wrong diagnosis. The third clinical case, more frequent, I guess, even if it's a rare case, or a confusing case. Maybe that's better wording for this one. This boy participated in a weight-losing program, and he did really a good job. I think he lost 10 kilos. And when the program was stopped, he had 81 kilos, 147. He had acanthosis nigricans at that time when he stopped the program. He had a normal HbA1c and a normal OGTT. A year or two later, we got a phone call from the grandmother of this boy. And she said he had done a brilliant job. He had lost weight so well over the last 2 months. But now she was kind of getting a little bit worried because he was drinking more, and she had done a blood sugar level because she herself had diabetes. And the blood sugar was over 360 milligram per deciliter. You can see he had lost 20 kilos. He was tired. And when we did further analysis, before I would again love to ask you this question. I guess a lot of people would think he would have a decompensation of his type 2 diabetes. However, he had ketoacidosis. 25% of up to 25% of newly diagnosed patients with type 2 diabetes can have this, but he had all antibodies positive. So he had classical type 1, but obesity as well. And regretfully, I have to say, he's back to his previous weight, which was around 130. He's now taller than 147, but still he's having a massive overweight or obesity. But he has a classical type 1 together with insulin resistance based on his weight. So diabetes is giving care, and diabetes is always critically considering who you've got in front of you and work together within a team and work together with the patients here in the mountains in Italy. I would like to thank you for your attention and invite you all to the meeting we'll have in Abu Dhabi, not far away from India, in October, where we'll have, I hope, again, a face-to-face meeting for ISPAD. Thank you.